everyone. This is a lecture on immunologic and drug-induced disorders. I am Dr. Lahari Thelang from Department of Oral Medicine and Radiology, Penang International Dental College. The learning outcomes would be to list 5 autoimmune diseases affecting the oral and maxillofacial region and explain their clinical features, oral manifestations, laboratory findings, as well as management. Also, to comprehend allergy and hypersensitivity reactions in relation to dentistry. Let's look at immunity as such, moving on to more immune-related diseases. Immunity actually gives protection against disease and helps the self versus foreign, or immunity is one which distinguishes self versus non-self. So immune response could be innate or acquired. Innate immunity is generally non-specific and it's an immediate response, whereas acquired immunity, which is adaptive, is more specific and takes several days to develop. So this is how we would classify or look at the hierarchical relationship of immunity. Innate immunity is generally inborn, and patient acquires it because of genetic factors. Whereas acquired immunity, on the other hand, is generally derived by active or divided into active or passive immunity. Active immunity is when you develop your own antibodies, which could be natural by getting exposed to infectious agents, like, for example, when you have an exposure to a viral infection, the body develops antibodies and hence gets a natural uh, acquired immunity. On the other hand, immunity which can be acquired by artificial methods like immunization, where antibodies are or injected into the body. On the other hand, acquired immunity can also be passive, where ready-made antibodies are given. This could be due to natural methods like from maternal antibodies, or artificial from other sources. When we're talking about immunity, it's also important to talk about oral defenses. Homeostasis is the method in which balance is maintained in the oral cavity. It is due to innate as well as acquired immunity. And the most important components which help in the defense mechanism in the oral cavity are saliva, salivary innate antimicrobial proteins, gingival crevicular fluid, transuddating plasma proteins, circulating WBCs, oral mucosal keratinocytic products, as well as proteins from microbial flora. So all of these put together maintain the homeostasis in the oral cavity. We've looked at what is meant by presence of immunity. Now, what is meant by presence of no immunity or immune deficiency? An individual who is not capable of mounting a normal immune response is said to be immune deficient. Now, it can be hereditary, secondary to infections like HIV, or secondary to major diseases like cancer, diabetes, or alcoholism, or due to transplantation of an organ or hematopoietic stem cell transplant. All of these conditions can lead to immunodeficiency in a human being. Autoimmune diseases. This is a condition or disorder in which there is evidence of an immune response against self. So, the cells of the body recognize some of the organs or tissues as non-self. Lymphocytic infiltration is seen in target organs, and examples of autoimmune diseases could be SLE, scleroderma, idiopathic inflammatory myopathies, rheumatoid arthritis, mixed connective tissue diseases, and many more. Let's look at scleroderma. From the name itself, you can understand that scleroderma means hard skin. This is a dermatological disorder where there are unregulated collagen deposition, which is the hallmark of the disease. There are varieties of scleroderma. The first one is progressive systemic sclerosis, where there is generalized diffused deposition of collagen. It could be limited to cutaneous scleroderma, which is called as a CREST syndrome, or it could be diffuse cutaneous scleroderma. The second variety is the localized scleroderma, which is more less affected, the lesser, smaller area affected, in the form of linear scleroderma or morphia. The clinical features of a patient who has scleroderma would be rapid skin thickening and visceral organ involvement. Generally, the skin is first involved, cutaneous involvement is seen, followed by musculoskeletal, GI, cardiopulmonary, renal manifestations as well. There could be Raynaud's phenomenon where there is lack of blood supply to the extremities, especially the tips of fingers, toes, as well as the nose also. This is also an example of the patient. You can see the typical features where there is a narrowed oral cavity, as well as the nose also appears narrowed and the skin appears stretched. Localized scleroderma, on the other hand, is primarily involving the skin with minimal systemic manifestation. Rarely this progresses to progressive systemic sclerosis. The linear scleroderma variety has generally a sword cut like defect on the skin. And in this enku, the seber or the sword cut is evident in the images which are here. You can see that the patient is having a skin defect on the nose as well as on the forehead region. So hence this is localized area of scleroderma. Morphia could be a more one side of the face is involved, and there could be a skin defect involving one part of the face. So, looking at the progressive systemic sclerosis and the more localized version, the oral manifestations would be lips becoming rigid, oral aperture narrows, which is also called as a purse string appearance. Skin folds are lost, giving the patient a mask like appearance. The tongue becomes hard and rigid, so that makes speaking and swallowing difficult. There could be dysphagia and xerostomia, which could be secondary to Jorgens. You must remember that scleroderma is a autoimmune disorder. So many of the autoimmune disorders generally coexist together, and hence there could be both connective tissue features as well as other systemic involvement. Oral telangiectasias can be seen on the lips and the hard palate. So what is important to understand is the patient could have a mask-like appearance, skin because of the skin folds becoming rigid and lost, and the oral aperture becomes smaller. So you may now understand that patients who have scleroderma features could be a difficult dental patient because of the narrowed oral aperture, and hence reaching the posterior teeth could become difficult during dental management. The radiographic features in the maxillofacial region would be widened periodontal thickening, periodontal membrane thickening, and this could generally be generalized, involving all of the teeth, like the image shown here. Also, extensive amount of sclerosis happening in the muscles could cause mandibular resorption at the angle and the condyle. Calcinosis of soft tissues also happens because of deposition of calcium deposits or calcification of the soft tissue region. Diagnosis of scleroderma is arrived at with the help of autoantibodies. The ANA, which is anti-nuclear antibodies, are seen in 90% of the cases, which is the anti-centromere type. Patient could have anemia, elevated ESR, and hypergammaglobulinemia. Management of these patients can be quite tricky. Calcium channel blockers are used in case there is Raynaud's phenomenon. D-penicillamine can be used in cases where there is skin thickening. Cyclophosphamide is used to detect early or to manage early lung disease. Dental management, like I discussed, limited mouth opening is the most important finding. So patients are advised stretching exercises, but it only gives up to 5 mm improvement. Poor oral hygiene is also seen in this patient. So patients must be caries index to keep it low. Topical fluorides need to be applied. Also, because of the extensive amount of fibrosis, there could be pathologic fractures in these patients in the jaw area, and that is something which has to be taken into consideration. Rheumatoid arthritis, this is a common autoimmune disease, and generally there is symmetric inflammatory arthritis of small and large joints. Why are we discussing it here in a dental context? Is because treatment of rheumatoid arthritis can cause oral manifestations. Long-term use of methotrexate could lead to stomatitis, and steroids like prednisone could cause opportunistic infection in patients. Dental management in patients with rheumatoid arthritis should keep in mind the drug regimen that the patient is using. Also, complete blood counts prior to invasive dental procedures have to be taken into account. Preferably, late morning appointments are given for these patients due to the stiffness in the joints and difficulty or discomfort that the patient might be facing. So this, for example, is a patient with rheumatoid arthritis. You can understand that if this is a situation, the patient of the finger joints, and then the patient could have similar manifestation in other joints, making it uncomfortable for the patient, and hence um, uh, patient's quality of life has to be taken into consideration.
Now, next is lupus. Now, lupus is going to be covered here as well as under the autoimmune disorders chapter. But let me give you a brief idea about lupus here. This is a multi-system autoimmune disease with formation of antibodies to DNA and involving immune complexes as well as B and T lymphocytes, leading to vasculitis. So the primary ailment that happens in lupus is vasculitis. There are various factors which aggravate lupus erythematosus, and those are environmental factors such as sun exposure, some drugs, chemical substances and hormones. There is genetic predisposition, and generally females of reproductive age, there's 20 to 40 year olds, are affected. African, the race is more affected than Asians and Caucasians. So lupus is also known as a great mimic because it tends to manifest features which could be similar to many other diseases. I've just covered this before. The skin is affected in 85% of cases, and the common manifestation is a butterfly rash. You could also have renal, musculoskeletal, CNS and cardiovascular involvement. The different types of lupus erythematosus: SLE, DLE, acute cutaneous, subacute cutaneous. The most important out of all of this is the fact that it's a potentially malignant disorder when it happens in the oral cavity. As an example of malar rash, which is seen on patient here, is a typical classical example of systemic lupus erythematosus, rash developing in the malar region of the patient. Right, so SLE, DLE both have similar oral findings. Very difficult to tell you based on the oral findings itself whether you're looking at an SLE or a DLE. You might have to do more investigation to find out the systemic component of the disease. So this oral manifestation may be the first sign of the disease. Now that means in 20% of the cases, oral manifestations would be the first sign of the disease. That means as a dentist, you have a very high chance of catching this disease early. That is if the patient presents to you. White striae with radiating orientation, sharply demarcating at the center of the lesion. Central erythema is also present, which is called as brush border appearance. I mean, there's central redness, and on the periphery you have white striae. It looks like a brush. So the differential diagnosis for this appearance of the lesion is lichen planus again, aphthous ulcer if there is an ulceration present. Okay, so this is an example of how DLE looks like: central redness with periphery having white areas. Okay, so central redness looks very typical like a disc. That's why the term discoid lupus erythematosus, with peripheral white areas, so which looks like a brush border appearance, right? So like a brush border appearance. Some more pictures, again looking very disc-like or coin-like with brush-like white areas at the corner. Center is mostly red. But this one doesn't look like a disc, it just looks like irregular red areas with the little white brush areas. Now looking at this disease on this particular case, you can see both sides of the tongue, bilateral, is very difficult to tell whether this looks like erythematous lichen planus or DLE. And that's what we were trying to, the point I was trying to get to earlier. So now again, this is a case of SLE manifesting as desquamative gingivitis, extremely erythematous. Now looking at this, you cannot think of it as simple gingivitis. Neither can you call it as periodontitis. There is so much of erythema of the gingiva, and it looks absolutely unexplained. Right, so this type of manifestation is called as desquamative gingivitis. So again, let me remind you, desquamative gingivitis is a clinical finding and not a diagnosis on its own. Right, so you could have even SLE which looks like desquamative gingivitis, lichen planus which looks like desquamative gingivitis, and to find out you will have to do a biopsy, and the best spot to do a biopsy from is somewhere near the pocket area. Right, there are 4 more criteria which must be positive in this American College of Rheumatology classification or criteria for SLE. Either a malar rash, discoid lesion, photosensitivity, presence of oral ulcers, that's the one which we were looking at earlier, non-erosive arthritis of 2 or more joints, serositis, renal disorders, neurological, hematological or immunological disorders. Right? So, the diagnosis of DLE could be well demarcated cutaneous lesions with scales and follicular plugging, that is malar rash. But in case when you don't have this and oral manifestations as first sign, then you know that you need to do a biopsy to confirm it. So systemic symptoms, in case of management of oral lesion, first of all systemic symptoms should be treated and symptomatic treatment administered. Again, we go back to topical steroids and immune suppressive drugs, of course keeping in mind the opportunistic infections that may occur.
Let's look at medication or drug-induced oral diseases. What could happen when certain medications are taken is they could lead to side effects. And this could be in the form of xerostomia, swelling, pigmentation in the oral cavity, gingival enlargement, oral lichenoid reactions, which could be non-specific ulcerations or mucositis, vesiculobullous-like lesions, which could appear like lichen planus-like lesions, erythema multiforme-like lesions, or pemphigus-like lesions, bisphosphonate-related osteonecrosis of jaws, or medication-related osteonecrosis of jaws. Let's look at medication-related osteonecrosis of the jaws. It's found in patients who have recently received intravenous or oral forms of bisphosphonate therapy, most commonly, for various bone-related conditions. For example, is osteoporosis. And the chief complaint of the patient would be exposed non-vital bone in the maxillofacial region, which is extremely painful, leading to swelling as well as causing pathologic fracture of the bone. The MRONJ could be caused by trauma, then it could be even a recent dental extraction traumatizing the dentoalveolar structures. And these dentoalveolar structures have limited capacity for bone healing due to the effects of the existing bisphosphonate therapy. And hence this leads to non-vital bone in the region, which is extremely painful condition. So this is how a defect could develop in the bone, and you can see in the image here there is exposed bone devoid of tissue, superficial alveolar mucosal tissue covering the bone. This exposed bone is extremely painful and is difficult to heal. This is also a case of medication related osteonecrosis in a patient who's 45-year-old who has a history of breast cancer and is on zoledronic acid, which is a form of bisphosphonate. And you can see in the image in the panoramic radiograph that there is a large bone defect, and the appearance on the radiograph is very similar to that of osteonecrosis or due to osteomyelitis, which looks very similar to osteomyelitis. In effect, the defect in the bone looks very much like my osteomyelitis. Um, Medication-related osteonecrosis of the jaw, the staging system which is given by the American Association of Oral Maxillofacial Surgeons, classifies it based on the appearance of the bone and the classic clinical features as stage 1, 2, and 3. Stage 1, there is exposed necrotic bone. Patient could be asymptomatic and there is no infection present. Stage 2, there is exposed necrotic bone. Patient is symptomatic with experiencing pain and there is infection of the bone. Stage 3, there is exposed necrotic bone. Patient is symptomatic, having infection, and having one of the following: either pathologic fracture, oral cutaneous fistulas, osteolysis extending to the inferior border of the mandible. Management of bisphosphonate related osteonecrosis or medication related osteonecrosis is primarily discontinuation of the bisphosphonate or the offending medication therapy. No dental therapy must be performed on patients who are receiving bisphosphonate therapy, and no dental therapy or minimally invasive dental therapy must be performed. For example, only root canal therapy instead of extractions. The management can also be divided into stage 1, 2, and 3. Uh, Primarily antimicrobial rinses with no surgical intervention. Stage 2 would be antimicrobial rinses like chlorhexidine with systemic antibiotics or antifungals, and analgesics are also added in. Stage 3 cases would be best treated with antimicrobial rinses and antibiotics systemically or antifungals, analgesics, and surgical debridement or resection of the affected part of the jaw. Moving on to lichenoid contact reactions in the oral cavity. This is a type of delayed hypersensitivity reaction to dental materials like amalgam and composites. The oral manifestation is generally confined to sites in contact with the dental material, most likely the buccal mucosa or the border of the tongue. These are rarely symptomatic and clinically appear very similar to oral lichen planus. Sometimes it's very difficult to differentiate them, and the most important differentiating factor would be to replace the restoration with a different restoration and see if the lesion persists. If lesion persists, then it is probably you're looking at a lichen planus, but if the lesion subsides, then you're looking at a contact reaction caused by hypersensitivity to amalgam or composite, whichever is the restoration present. Histopathologically also, oral lichen planus and lichenoid contact reactions look very similar to each other. So this is a case which shows you an amalgam restoration in a molar which is present on the occlusal as well as the buccal surface. And the buccal is the one which is contacting the buccal mucosa. And once the restoration is replaced with composite, you see that the reaction on the buccal mucosa actually subsided. So that means that this patient had a lichenoid contact reaction to amalgam restoration. This is another example of PFM bridge, which was causing allergic reaction on the palatal region for the patient. And once the metal part was removed after a coin test or sorry, a patch test that was done, you can see like the redness around the forearm. That means that person would have been allergic to that particular component in the metal component in the PFM bridge. And once that was changed, you see that when it was shifted to a all ceramic bridge, the redness has subsided. Allergic contact stomatitis is a terminology which is also referred to as stomatitis veninata. This can happen to foods, food additives, toothpaste, mouthwash, even gloves used within the oral cavity, rubber dam, candy, acrylic cinnamon flavoring, as well as it can lead to appearance of erythema, superficial vesicles, and epithelial desquamation. On the other hand, stomatitis medicamentosa is allergic reaction to systemically administered drugs. This could be in the form of anaphylactic stomatitis or mucosal fixed drug eruptions. This is an example of an oral lichenoid reaction to medication. So the patient is probably swallowing or systemically taking some medication which is not suiting the person and develops an allergic manifestations in the oral cavity in the form of a lichenoid lesion, and hence this is called as a oral lichenoid reaction. And this is not a contact reaction but a general oral lichenoid reaction. Let's look at some transplant related disorders in the oral cavity. The oral health consideration for a patient who is receiving a transplant is to be taken into account when there is an organ transplant, hemopoietic cell transplant as well. The complications could be due to end organ damage from pre-transplantation conditioning therapy, or due to graft versus host reactions, or due to infections related to the transplantation process itself. So, oral manifestations in cases of patients who have received a transplant could be primarily infections. Bacterial infections are not classical and they do resolve, and prompt antibiotic therapy is required. Patients could have increased caries index and poor periodontal health, which could lead to gingival overgrowth. And this can be efficiently, and this is more commonly seen in drugs such as cyclosporin, which are used in transplant patients. Viral infections that are seen in transplant recipients could be herpes simplex virus or chronic recurrent intraoral herpes, and the multi-drug resistant variety of herpes simplex viral infection, as well as oral hairy leukoplakia, which is caused by Epstein-Barr virus, as seen in the picture here, which is commonly seen as white non-scrapable appearance on the lateral border of the tongue. Fungal infections could be most commonly like Candida, causing pseudomembranous or atrophic type of candidiasis, or deep fungal ulcers caused by aspergillosis, mucormycosis, or blastomycosis. The picture here is an example of pseudomembranous candidiasis along with erythematous component. Non-infectious oral manifestations in transplant recipients could be lymphomas, Kaposi sarcoma, or squamous cell carcinoma of the lips. Graft versus host disease, which is very similar to oral lichen planus or lichenoid drug reactions in the oral cavity. Also, non-gingival soft tissue growths, oral mucositis, salivary gland dysfunctions, and developmental tooth defects and dentofacial anomalies if the graft recipient is or transplant recipient is a child. This is an example of graft versus host disease, and the growth that is seen on the buccal mucosa as well as on the ulcerative area on the tongue are not very typical to either lichen planus or any of the other forms of disease commonly known, and hence appearance like this should be attributed to graft versus host disease, especially with the history of transplant recipients. When we are considering oral health in transplant recipients, it's important to look at pre-transplant considerations as well as post-transplant considerations. In pre-transplant consideration, when the conditioning of the body is done, all dental treatment must be finished prior to the transplant procedure itself. And in case of post-transplant, only emergency dental management should be taken into consideration, as well as only specific management needs must be addressed till the patient is in a stable, healthy condition. So this is a table which shows us the dental management considerations in pre-transplant consideration. Significantly ill patient with end organ damage, medical consultation is required, and consider postponing elective dental treatment. It's important to obtain laboratory information or supplementary information such as blood counts with differential crown, prothrombin time, the plasma thromboplastin time, and international normalized ratio, metabolic panel, as well as liver function tests and other organ specific panels. It's important to become acquainted with specific management issues like blood products or prophylactic antibiotics, and alternative medication regimens due to organ failure that may need to be employed if the treatment is rendered. Also, dental consultation prior to anticipated transplantation. You should rule out acute dental infection sources and stabilize the oral disease. Remove sources of chronic infection that may lead to acute complications within the transplant process itself or during the immediate post-transplant period, and perform necessary treatments that is required during the consultation with transplant physician to determine medical risk versus benefit ratio. In post-transplant consideration, immediately after transplant surgery, generally no elective dental treatment is performed. Emergency treatment is only done under the with the consultation of the medical or physician, and considering specific management needs of the patient only. During the stable period after functioning transplant, elective treatment may be performed after consultation with the physician, and issues of immune suppression must be recognized. Oral mucosal diseases must be diagnosed and treated, It's important to evaluate oral hydration, salivary flow, and supplement or treat the patient with silogogues. Supplemental corticosteroids may be necessary in consideration for antibiotic prophylaxis due to immune suppression. Generally, when antibiotics are required, oral amoxicillin or 2 grams of oral amoxicillin or 600 milligrams of clindamycin are suggested 1 hour prior to invasive dental procedure. And considerations for specific management needs like chronic rejection period or only emergency management treatment is generally done. Moving on to hypersensitivity reactions, these can be classified as type 1, 2, 3, and 4. Type 1 is immediate or anaphylactic reaction where the patient manifests with anaphylaxis, asthma, or hay fever. Cytotoxic reaction where the patient manifests with pemphigus-like disease or idiopathic thrombocytopenic purpura. Immune complex is type 3, which is diseases like rheumatoid arthritis, serum sickness, or lupus erythematosus. And type 4 reactions are delayed hypersensitivity reactions like contact dermatitis or mm, reactions to dental materials or graft rejection. Anaphylaxis is important to consider in the dental setting. There's acute allergic reaction, which could be caused by immediate hypersensitivity reaction mediated by IgE or mast cells. It could be localized as urticaria or angioedema, or generalized, which is more like anaphylactic shock. So, in dentistry, generally with antibiotics like penicillin or muscle relaxants, cephalosporin, sulfonamides, vancomycin, or radiographic contrast media and vaccines are all of the ones which could lead to anaphylactic shock. This is an example of urticaria, which is like a wheal and flare reaction. The patient develops rashes all over the skin surface. Angioedema, on the other hand, is swelling of the facial region, generally the lips or the cheek area. This is a case of a 54-year-old male gentleman who had an angioedema due to some of the medication which were prescribed in the dental setting. And you can see that before and after the angioedema has subsided, the extent of amount of swelling that was present. This is also an example of angioedema where only the lips were enlarged, and after it subsided, how the patient's lips appear. The factors which increase risk of anaphylaxis include presence of history of allergy to other drugs or food, history of asthma, family history of allergy, which is also called as atopy. Parenteral administration of the drug increases the chances of anaphylaxis as opposed to oral ingestion. And anaphylaxis is something which occurs seconds of the drug administration, within seconds or sometimes minutes, for let's say sometimes after 30 to 40 minutes as well. Moving on to latex allergy, you can see that there is severe rash as well as peeling of the skin on this image of the finger on palm of the patient or the user here. Latex allergy is seen in about 10% of the dentists. It can occur as early as second year of glove use. What happens is there is high sensitization. Inhalation of glove powder also can cause asthma-like symptoms. So, patient could have type 1 hypersensitivity reaction and contact dermatitis. Cross reagents that are also contribute to latex allergy, or patients who are having latex allergy could have cross reacting agents found in bananas, kiwi fruit, avocado, and chestnut. Surprisingly, all of these could also have agents which could cause allergy. So, the management of a patient, or rather an operator or dentist who has latex allergy, is good history taking. It's important to note that the patient history of latex allergy also to be kept in mind. And alternative use of non-latex gloves, for example, nitrile gloves, and avoiding latex containing products. Also, to keep epinephrine handy. So that brings me to the end of this chapter. Most of the references have been taken from Burkitt's Oral Medicine, and some of which have also been taken from Southam and Soames. So if you do have any doubts, feel free to contact me. Thank you.